Here we go. So culture and psychosis. Here it is, the big city, the culture of Euro America. Look at all that. Look at all those mountains of material. It's just amazing when I go to New York City. I look at like literal mountains of bricks and steel. It's crazy. So this is the kind of culture we come from, urban North America. And there are problems with urban North America. Urban North America causes psychosis, apparently. Urbanicity is a fairly potent risk factor in many settings for onset of psychosis. We could talk about why that might be, but first I want to talk about the cultural shaping of psychotic symptoms. So every symptom that we have, every behavior we have is shaped by the milieu we live in, as you all know. I just draw from my own religious tradition and I ask you a question. If you had somebody tell you this in your office, how would you respond? While I was thus in the act of calling upon God, I discovered a light appearing in my room, which continued to increase until the room was lighter than at noonday, when immediately a personage appeared at my bedside, standing in the air, for his feet did not touch the floor. He called me by name and said unto me, he was a messenger sent from the presence of God to me, and that his name was Moroni, that God had a work for me to do. After this communication, I saw there's a little dot, dot, dot there. There's a lot of extra stuff I cut out to make it possible to present this. So it's an extensive report. After this communication, I saw the light in the room begin to gather immediately around the person of him who had been speaking to me, and it continued to do so until the room was again left dark, except just around him, when instantly I saw, as it were, a conduit open right up into heaven, and he ascended till he entirely disappeared, and the room was left as it had been before this heavenly light had made its appearance. So what would you do if someone starts talking like this to you in your office? This kind of experience. How would you respond? You're all nervous, you're walking on a minefield. Any thoughts, any reactions?
Well, sorry, what does this means to you, right? We just want to know more. So you describe the experience, but like how meaningful it is for that person.
Yeah, sure. Excellent. That's a good way to go. What if you're in the emergency room? What would you do? In the ER and someone starts talking like this. They're brought in by somebody who's worried about them. He's been staying up late at night, not coming to meals with the family, and then he says this to you. You want to know more about it? Anyone would have, I don't know. I mean, I'm kind of begging the question. I think most people in our time would probably see this as worrisome, a potentially worrisome problem. This is what I'm trying to kind of convey to you. Share an example. The interesting thing is that our culture shapes, though, how we respond to these kinds of experiences. So, in the case of Joseph Smith, who was the founder of my religion, he had a series of visions and revelations in the 1820s. When he was a young man, he was probably 14 to 25 when a lot of these visions happened, at the peak period of onset of first episode psychosis. But when he went and told his father about this experience, his father said, "It's of God. Go and follow exactly what the messenger told you." Kind of an unusual response for our time, but in his time in 1820s, on the frontier of the North American settlements, would have been in New York State. There was a framework, a religious framework that a lot of people believed in. And so an experience like this, for some, not everybody accepted this back then. A lot of people thought it was crazy then, or at least misguided. But enough people at the time thought this was a possibly valid experience that it allowed Joseph Smith to found a new world religion instead of going to the insane asylum. So the cultural frames we live in and operate on in are extremely powerful. It can really change how we understand what people are talking to us about, even with what could be called frankly psychotic symptoms. Now, these kind of frameworks infuse our professional cultures as well, so that psychiatrists in the UK, the US, and in France, for example, have very different approaches to diagnosing and counting rates of psychosis in minorities and migrants, say. So in the UK, typically the literature talks about high rates of psychosis in migrants. I put a picture up here, bit of a confrontational battle, colonial battle here between British and African peoples. And the battle has kind of moved over to the British society now in some ways. So migrants are seen as sort of being vulnerable to psychosis and bizarre and aggressive behaviors. In the US, though, a very different story. In the US, since the civil rights movement, this may change now, where everything's in flux. This has been a strange time. But since the civil rights movement in the US, there's been more of a focus on egalitarian rates of diagnosis, equal rates of diagnosis in Black people, in all minority groups. So the US has favored sort of an equal rates of psychosis. It used to be in previous decades before the civil rights movement, scholars found high rates of schizophrenia in African Americans. But since the civil rights movement has changed to become more one of an equal, and when unequal rates are found in the US, scholars tend to blame clinicians. They say, well, they're misdiagnosing people with schizophrenia, Black people with too much schizophrenia. In France, if you go to France and talk about these issues, there are really no rates of psychosis, or very few. There have been some studies attempted to get data from France, but generally speaking, rates of schizophrenia for migrants and minority groups are really hard to find because in France, um, the government has made it illegal to gather ethnic and religious data in the census and in other research settings. So the culture of France is not to examine these problems the way we do in North America and the UK. And so it's the culture of society and that influences psychiatry, which influences how we number, diagnose, and understand the people around us as they're coming down with schizophrenia and psychosis. What about Canada, you might say? Well, Canada sort of goes with the American point of view, although it hasn't really been evaluated too much here, but there's been some work in Canada. This is more American data here, talking about how Black people in the United States have been sort of overrepresented with schizophrenia diagnoses. There's been a disparity of diagnoses in which Black people in the United States have less mood disorders, which can be explained by an increase of diagnosed schizophrenia and other psychotic disorders like schizoaffective disorder. Up through World War II, it was a schizophrenia or bipolar kind of uh, question for Black people. Too little bipolar, too much schizophrenia. After World War II, it's evolved into more of a question of is it schizophrenia or is it depressive disorder? And for a long time, many decades now, African Americans have been diagnosed with less depressive disorder, lower rates of depression than, say, white people. This has been replicated many times. In fact, a very interesting study from the 90s in Texas, they just looked at people who were admitted to psychiatric hospitals, and they found that Black people over time, the longer you spent in a psychiatric hospital, the more likely you'd end up with a schizophrenia diagnosis, even if you entered without one. And the opposite was true for white people. If you entered with schizophrenia diagnosis, you would tend over time, you tend to drop your schizophrenia diagnosis. So these are stereotypes, they're cultural issues, they influence our practice, They influence how we understand the people that we're seeing in our clinics. You can talk about causality. How do people understand the cause of psychotic symptoms? You can go to the Intrepid study by Cohen et al. In 2016. They found that people around the world had a number of different causes. Some of them were very familiar to us, biological causes like family inheritance, brain injury, substance use. Other people would talk more about family problems, thinking too much, and others might even invoke supernatural causes for psychotic symptoms. Black magic, spells, demonic possession. I'll give you a couple examples of them here. For example, one healer in India talks about black magic was the most often cited supernatural explanation. He says, it's all black magic. They do it purposefully to destroy the next generation of the family. In a site in Nigeria, a caregiver talked about casting spells. If a child is meant to be great, the evil people are likely to cast a spell on him to hinder him from attaining his goal. In Trinidad, a traditional healer said something like this. People would want to say, is it obia? Is it voodoo? Is it black magic? Talking about, in this study, they talked about madness. They were talking about madness with people. What causes madness? Not specifically psychosis, but it kind of the designers of the study were using madness to represent schizophrenia and related disorders. Culture affects how we understand hallucinations as well. How, if we even find them important at all. 100 years ago, schizophrenia concepts were not so interested in hallucinations. It wasn't until the middle of the 20th century, Kurt Schneider, who was a prominent German psychiatrist, he developed something called first-rank symptoms. And first-rank symptoms held hallucinatory behavior and delusional behavior, different kinds of hallucinations and delusions. Very, very important. And so since the 1950s, auditory hallucinations have become very closely tied to schizophrenia for a lot of people in Europe and North America. But hallucinations are culturally sanctioned uh, experiences for many people. You don't have to be psychotic or have a psychotic disorder to have hallucinations, as you know. We may live in a society that may tend to reduce the overall rate of reported hallucinations because we value rationality so much and individual liberty and individual agency so much that to admit that you have experienced hallucinations or see visions could undermine your status so deeply that people just may keep those experiences to themselves. And the ones who don't end up in psychiatric care often. Tanya Luhrmann is the most prolific author in this regarding hallucinations and the role of culture in hallucinations. And she published a number of interesting papers, one of them coming out in our own journal, Transcultural Psychiatry, very soon. But in this one here, this kind of early one in 2016, she talked about how the cultural surround can shape and change how hallucinations are perceived by people. And her respondents in California, many of them, their hallucinations were very negative and exhorted the hearers to attempt suicide and have a very negative view of themselves. Whereas in other settings, she found that the auditory hallucinations were much more benign or even sometimes had a helpful component, a community component, or may have represented discussing issues with members of the family or those who have passed on. Hallucinations can be part of PTSD. Generally speaking, this is true for delusions as well. The more horrific, unpleasant, or bizarre a hallucination is, the more likely it's linked to a pathologic syndrome rather than a culturally acceptable variant. But hallucinations and delusions are often culturally meaningful. They're not just bizarre and strange, even the ones that seem kind of strange to us. Looking at delusions, for example,
Hi, Krishna. No, it's fine.
I'll just mute Sebastian. There we go. So culture and delusions. Delusions, as you know, vary from overvalued ideas up to frankly delusional, bizarre material. 15% of the non-clinical population may have actual delusional ideation. And a lot of people have delusional beliefs. We'll look at a table coming up soon to talk about this. As for hallucinations, we can mistake some beliefs as delusional when in fact they may be fairly widely accepted among a certain cultural community. So here's some examples of a general population sample of what people may believe about various things. So if you're the kind of person who believes that believing in God or gods is sort of on a delusional, could be on a delusional spectrum, a lot of people with psychotic symptoms are seen as having um, are seen as being psychotic. You know, so it's a bit of a tension. How do you believe in God or gods and not be psychotic in our times? This is a bit of a question for a lot of religious people. It depends how far you go, how extreme maybe. So Pecci and Halligan had this interesting 2011 sampling of the British general population. And, believing in God or gods, at least back 10 or 15 years ago, 70+% of people may endorse that, so it's not super unusual. What about transforming into werewolves? A little more strange or odd. Less than 5% of the population endorsed that kind of belief, but some did. Astrology, as you can see, kind of a middling kind of a response. Up to 45, 50% of people may endorse some belief in astrology. So it just goes to show you how pervasive various beliefs are, and many of them assume non-psychotic dimensions and maybe actually just part of cultural or community practices. What about other kinds of delusion-like beliefs? Like, for example, nihilism. The world is about to end. Now, this may be changing. More people now may believe the world is about to end with all the things that are going on politically in the world. Back in this interesting study, 14, 15 years ago, you could see about 12, 13% of people overall endorse some belief in this kind of idea, sort of maybe a baseline belief. Um, some some beliefs like body dysmorphia, your body or part of your body is misshapen or ugly, approaching half of the population may sort of endorse those kinds of beliefs. So you can see that delusions are really widely open to shaping by the surround and by the environment we live in, the different kinds of beliefs and practices that we're exposed to. I hope I'm kind of just trying to convince you that when you meet with people, they're telling you all their stories and their experiences. We have to have a little bit of an abundant caution, I would say, before just writing people off as being sort of psychotic and not really in need anymore of interpersonal interaction as much. We have to just wait for the medications to take effect. How some people view psychosis in our time. And then eventually they'll settle down. We can kind of get back to normal conversation. What about insight? Let me see how I'm doing for time here. Whoops, sorry, this is my example of insight. So insight in psychosis is a sociocultural process. You can have hybrid insights, like you have hybrid identities. So you might believe on the one hand that medications are helpful to you, but on the other hand that God is helping you. Or you might believe that somebody is really coming after you, but that if you take your medication, it's less urgent. So you can have hybrid explanations for the experiences you're having, including the psychotic experiences that people are having. So we have to we often declare people as lacking in insight or having absent insight if they don't understand that they have an illness and they need treatment. But that's one small fragment of insight, and the cultural and social dimensions of belief systems and the understanding of one's own predicaments are much more varied and interesting. Philip K. Dick is a famous author. He wrote the book Do Androids Dream of Electric Sheep? And this book was made into two movies, Blade Runner 1 and Blade Runner 2. And he had a psychotic experience, famously. He died quite young, sadly. But he had a famous experience where people call it a psychotic episode. And when asked to explain his psychotic episode, he's a good example of hybrid insight and explanation. He said, I can hold two normally contradictory beliefs, explanations. One, I became totally psychotic and projected and imagined all that religious supernatural stuff. Or two, the guide and savior, the figure of that beautiful woman who I met, whose voice I kept hearing, whose existence during my psychosis I imagined, was and is completely real. And I know when the need arises again, I will find her once more, or rather she will find me and again guide me. So we held these kind of ideas simultaneously, which I think a lot of people do. A lot of our patients may do that. And I just put it forward to you um, for Philip K. Dick. He's a talented author, a moving writer, so his ruminations are of particular interest. But which explanation do you prefer? Do you prefer that he psychotically projected all and imagined all that stuff? Or do you prefer the explanation that there's someone waiting out there for him who one day may come back to help and guide him in his time of need? I mean, it's a little more poetic, a little more personal, a little more meaningful, the psychotic explanation. And can be for a lot of our patients. What about stigma? Stigma in psychosis is very real and profound. The main purpose of this slide is not to go into a long discussion about Irving Goffman. It's more to tell you that studies that examine the role or where does stigma exist and how does it affect people find that stigma is present, stigma about psychosis is present almost everywhere. And it carries vast and negative connotations for people who are affected by psychotic symptoms and who are deemed to be insane or mad by the people around them, no matter what the culture they're from. Treatment of psychosis is affected by culture as well. Um, the most common way we can understand this relationship is by those who actually seek treatment and those who do not ever come to treat towards see us. So there's a number of psychotic people, people with psychotic symptoms. Many blend seamlessly into the general population. Some have more severe psychotic symptoms, and many of them may not come to see us until their symptoms reach a certain threshold of disruption. So people who are quietly living with psychotic symptoms, what we would call psychotic symptoms, they may not call them psychotic symptoms, maybe out in the communities. We're trying to help and serve. People from certain or ethnocultural communities may therefore not come to treatment as often. They may have more complicated pathways to care. They may drop out of treatment once they're coming to see us. They're less likely to be referred to psychotherapy. In low and middle income countries, 80 to 90% of people with serious mental illness, meaning people that we would probably diagnose with bipolar disorder or schizophrenia, and who have disruptive symptoms in addition, not just quietly psychotic at home, remain untreated, meaning they don't have access to antipsychotic medication, psychiatric evaluation, and psychosocial interventions we would deem really basic. Social interventions like finding work or work reinsertion and those kind of things. Minority patients may feel unwelcome or misunderstood by mainstream mental health services. So it may create a negative feedback loop of low expectations, dissatisfaction, and perceived or real discrimination. What about coercion? Now, coercion in Black Canadians, we're talking, our current project is working with Black communities. We're talking mostly in these seminars and today as well, focusing mostly on Black people and African communities in Canada, United States, UK, other places. So coercion in young Black people is very real. It occurs at about twice the rate. And when police stop and search people, about twice as often are Black than white. In Toronto, Blacks are 50% more likely to be taken to a police station for processing after arrest, and 100% are twice as likely to be held overnight than white people. When given bail, Blacks tend to have more conditions imposed, and Black rates of incarceration in federal prisons are 3 times those of whites. This is from 2017. It's 5 times for Indigenous people. So Indigenous people even have more problems than Black people do in certain settings. these trends may be worsening over time. These are very real. They're old findings. They're not controversial, unlike certain people would say nowadays in certain government positions. These are not controversial. These are findings going back to the 1960s. They've been replicated dozens of times with very good methodologies in many different settings. So there's really no discussion on the discrimination faced by some of our ethnic minorities in Canada and elsewhere. Just an example from one of our studies in 2023, qualitative study, one of our Black patients in the qualitative portion of the study said the police told me to drop the knife, but I didn't realize it was happening. The situation escalated very quickly, and I ended up walking, and the police just hit me with the car, and I dropped the knife at that moment, and they handcuffed me. An occurrence, an occurrence of similar ones like this, all too common, especially in young Black men with psychosis. Recovery from psychosis is, of course, shaped by the same forces we've been discussing over the last half an hour. Rob Whitley is an expert in recovery. He works at the Douglas Hospital. He did an interesting study in the inner city of Washington, D.C., where he talked to people with severe mental disorders. Many of them were African American, from the Caribbean as well. And he found that God and religion were important elements of recovery for his Black patients, and not so much for European Canadians or Euro Americans. Apart from this finding, he found few other differences that emerged between the two groups, but he highlighted this role of religion and religiosity and spirituality as being so important and significant. So it leads the way to culturally adapted interventions for early psychosis. There haven't been so many, there have been some. The ones that we have, we know that where cultural adaptations have been attempted, they're generally linked to better outcomes for the communities that are being targeted by these interventions. They using culturally adapted interventions like in CBT, cognitive behavioral therapy, for example, reduce symptoms better than standard interventions. Components might include translated materials, use of specific phrases and metaphors that are useful and more better understood for community members, for cultural members of cultural communities. Logistical modifications like when and where a person meets and what times, and regard for religion, spirituality, family factors, and culture-specific communication styles. I hope to illustrate some of these. Okay, so we're coming up on a couple of clinical examples, but I'm going to open up to the floor rather than share my examples. Or maybe I'll share one of them. This is kind of unusual. One's about negative symptoms, one's about positive symptoms more. I think negative symptoms are harder to understand, maybe in cultural context. Clinical tips. So how can we adjust our practices as clinicians? How can we be more culturally, how can we introduce more culturally adapted care in the daily interactions that we do as clinicians? This is what we've been trying to do for 25 years in the cultural consultation service at the Jewish General and other places around the world who've adopted a similar approach to working with diverse clinical clientele. So one of the first things you can do as a clinician when you're working with your new psychosis patients is determine if there's a need for linguistic and or cultural interpreters. It takes more time, it's true, but it really can be rewarding. You can develop a much better alliance if the patient gives authorization for you to reach out to linguistic or cultural interpreters. The bond can be the therapeutic alliance can be much better, much more rich, and the amount of clinical information you can gather is quite remarkable. There are some tools you can use in the DSM-5 to help you. One is called the Outline for the Cultural Formulation. The other one is the Cultural Formulation Interview. The outline is more qualitative and more open-ended as an interview guide. The cultural formulation interview is more directed. It's semi-structured. It's 16 items, and it can act as a springboard for the clinician into learning more about certain aspects of culture and migration. Always allow extra time for linguistically and culturally diverse patients, especially if you have a linguistic interpreter present. I allow about twice the normal time to evaluate that person. You need to identify priorities that may not be related to mental health symptoms, like symptoms of psychosis, like upcoming asylum hearings, finding legal counsel, procuring healthcare coverage when someone's here without any healthcare, finding shelter if someone's homeless, and securing a work permit. These are practical matters that may be much more important to your patient than if they have auditory hallucinations or even if they're suicidal. We as clinicians always strive to cultivate cultural humility, a recognition that we don't know everything about our patients, and that our patients and their families can have a lot of information and knowledge about their loved ones' health and illness, and what would be best to help them recover. We need to adopt a flexible approach. Some people come late to meetings. We need to find a way to see those people if we can. Lateness and being on time is a cultural construct that not every group or community is familiar with. We need to adopt a flexible approach working with families as well. We need to be a little more willing to be self-disclosing to some members of cultural communities. If somebody asks me if I believe in God, I may tell them that I do. Or if they ask me if I'm a member, if I'm a Christian or whatever, I'll tell them what I am. I don't try to hide or conceal those things. I'm working with some members of cultural communities or other patients in general. It's a way to be more adaptable and flexible and more personal and a little less rigid, I guess, or what do you call it? Formal, a little more informal. We need to train ourselves to be more self-reflective. What do we or what do I represent to the people coming in to see me in my office? What aspects of our society, of our Canadian society, am I representing? I mean, unwittingly, I may not even realize I'm representing authority, I'm representing coercion, I'm representing possible or probable discrimination, am I representing wealth, am I representing wisdom because of my age, or all these, gender, all these things have to come into our discussion. We need to work to engage I know in first episode Psychosis, most of you work with families already. We need to engage families as much as possible and consider alternatives to a psychosis diagnosis. If I see young Black men, 25% of our patient population is Black. I often refrain or defer diagnoses of psychosis and wait to see if a mood disorder may emerge over time or a post-traumatic stress disorder may emerge that hasn't been apparent to me after the first 2 or 3 assessments. So, I'm sorry to kind of go on and on like this. Let me come out of this share. I have a couple of clinical cases we could certainly look at a little bit together, but I don't know. I'd like to hear if any of you have any cases to share or questions. It might be better just to hear what you've gone through, what you've seen. If any of this resonates or you disagree with some of the things I've mentioned. Um, give you a couple minutes if anyone has anything to say before launching into a couple of clinical stuff, a couple of clinical vignettes. Anyone have anything to add? I know it's the lunch hour coming up. Might be a difficult time for discussion, these kinds of issues.
I have a question. A few days ago, no, actually it was yesterday, Lai and I interviewed a young Black male. It was a very rich interview. At the end of the interview, he asked, but why Black people have so much psychosis? And, following the literature, I would say, psychosis happens to everyone, age, just there are some triggers, can be the city, can be immigration, housing, and things like that. And he said, but the clinic of where I am, I see so many Black people. And I said, it's the catchment area, there is the university, things like that. So I just wanted to, is this the reality? I mean, is it true that, psychosis happens to everyone? We know, but
Sure.
is there a larger percentage of psychosis among Black people that, I mean, justly diagnosed, I'm saying.
Right. Well, this is kind of an ongoing debate, I guess. But I mean, if you take the British literature, for example, the British literature is bringing back in social causation theories of psychosis. So if a community is socially disadvantaged, they would expect to find higher rates of psychosis and schizophrenia in those people, because of social causation. That we're talking about the role of poverty, the role of discrimination, lower social capital that's available. Ethnic density is less in certain communities than others. Ethnic density meaning there's a higher percentage of Black people in a neighborhood. It seems to be protective against onset of psychosis. So there might be something that some protective factors are available that aren't if a person's a very tiny minority in a community, say, for example. So that's the British way of looking at things. On the American side, uh, again, uh, African Americans are often found to have higher rates of schizophrenia. There hasn't really been a good schizophrenia study done in the United States since about 2000. Okay, because the Americans became disenchanted with large-scale epidemiologic studies for schizophrenia. Many of the scholars came to the conclusion it's not really possible to do it properly. So they stopped conducting those kinds of studies. And instead, in the United States, it is more of a misdiagnosis problem. So they would say that we have to be very careful how we're diagnosing people, and we may be misunderstanding their symptoms of depression, say as negative symptoms of schizophrenia or even paranoia. And there's the concepts of cultural paranoia. Arthur Whaley and different authors talked about cultural paranoia or cultural um, suspiciousness, which is appropriate to a certain level in African Americans, obviously, because of all the social vicissitudes they've had to face, especially discrimination by police forces. So the question, so what I would answer to a person like that, I wouldn't go into a long thing like that for the person. I would say that in urban, inner city areas where a lot of minorities might live, and in challenging circumstances, there might be higher rates of schizophrenia, not just in Black people, but in all communities that have to live in those circumstances. That's what I might say. Something like that, So the downside of saying that Black people have high rates of schizophrenia, even in migrant populations, is it stigmatizes the whole communities, right? So I just don't know if there's value even in widely disseminating findings like that, because I don't know if we have any great treatments to undo the high rates, you know. If you're looking at society-wide problems like discrimination or poverty, we've been fighting poverty. The war on poverty has been going on since Lyndon B. Johnson's 1965 executive order, which was just overturned by Donald Trump, strangely. So, we've been fighting it for 60 years, and it's hard to know how to intervene. But the stigma is very real, and it's always there when you brandish a certain diagnosis and tar and feather a certain community a certain way. Those outcomes are real. So I would try to find softer ways of explaining that it's a shared dilemma with other migrants and so on, and other people living in inner cities, And then I would focus on resilience factors, religion and spirituality, if that's a factor for them, something important to them, or family dynamics, family strength, and their desire for education and those kind of things. Anyway, that's a very good question and point. Um, Yeah, if anybody has any other questions, let me know. I don't want to put people on the spot. I can go back to sharing here some clinical stuff. This is kind of more of an example of negative symptoms. So just for everyone to say, I think how much time? We have a few more minutes. So this is an example of a 40-year-old man from Guinea in West Africa. He was referred to cultural consultation a few years ago for evaluation of psychosis. And this is the picture we found. He'd been living in a shelter for 5 years. He was resisting efforts to find for people. He wasn't accepting people to help him find housing and employment. He seemed to kind of prefer to live in this shelter downtown. He was content to sleep on a mat by night, and he'd store away his meager possessions by day, and he'd leave the shelter for part of the day, then come back. He'd lock up his things. He always carried a well-worn Bible, which he brought to our evaluation, and said he was obeying God's commandments as best as he could. He explained that since being touched at the age of 9 years, he had felt God guiding and speaking to him continuously. And he reassured evaluators that the Lord would provide and show him the next steps to take. Meanwhile, living on practically nothing, which to him was a virtue, allowed him to spend most of his welfare allowance on his family, send most of his welfare allowance to his family in Guinea, which was really was most at stake for him, was taking care of people back at home, more than his own personal convenience or advancement. He appeared remarkably tranquil, given his destitution and his meager life. Here was our commentary. Well, here, before I do that, sorry, whoops. I'm going way ahead here. I'm supposed to come out of share again and embarrass everyone. Any reactions to this kind of situation? Have you seen anybody like this or any other? It could kind of be seen. We thought maybe he had sort of prominent negative symptoms. It seemed initially kind of not motivated in the traditional ways, highly motivated in some ways, maybe not in others. I don't know if you have any thoughts or reactions as clinicians to this kind of dilemma or this kind of person. If not, I can share some commentary. How are we doing for time? Yeah, what is time? Okay, good. Well, here, I'll share what we kind of thought, the cultural consultation team, which may or may not be true. The cultural we had a culture broker, fortunately, working with us in this case, and she explained that the patient's condition, i.e., no home, few possessions, was consistent with the lives of the poor in many African societies. A diagnosis of mild psychotic disorder was deferred in favor of a cultural formulation. So we noted in this formulation his rural origins, he had low secular education, his religious worldview was the prominent way of understanding things for him, and it was imperative, he had an imperative to provide for his family. So our recommendations were kind of practical. They included helping the man to obtain legal status in Canada. He was actually entitled to it. He'd been in Canada for quite some time, and he had the proper, we could move forward, we thought, on that front. Linking him to a supportive religious community. I don't know if he was super interested in joining a community, but we thought maybe we could try to support him in his efforts if he was okay with that, and bettering his connections to family in Africa. Medication and medical follow-up were not indicated in this case. So I don't know, any particular reactions to how we decided to proceed? You can see we kind of shied away from a diagnosis of psychosis. We focused more on a formulation to understand the person and more what was at stake for the individual. And we also didn't push medication or formal psychiatric follow-up at that time. We thought there were some other things we could do first in the community it would spare this man maybe unnecessary exposure to treatments he may not really, first of all, accept or really need. Reactions? I have just one more we could do. if you want me to proceed in this way. Clinical example number 2. So this is a man from the Caribbean, 25-year-old Haitian refugee. A claimant explained that she was chosen in childhood by what she called a loa, or a spirit, to become the family's spiritual leader. She realized this through a vision that she had, in which people were performed a particular night song. This is just what she was telling us. I mean, I know no more, no less than what we didn't know any more or less than you might just by hearing this. She regretted not having chosen to, quote, sit the spirit, unquote, who was a trickster being wooed by her brothers. In the, she doubted her, meaning her brothers in uh, her physical brothers in real life. She had other siblings. She doubted her own chosen status. She thought that her older brother would be better prepared for the role of taking on this role for the family. While she desired stronger faith to accept the spirit, or Loa, and usher in peace and prosperity, she also felt the need to work hard to get things for herself. So we kind of were already injecting a little bit of cultural analysis. Um, she had some aspects of a voodoo worldview, some aspects of a Protestant Christian worldview as well, working hard to get things for herself, and then having accepting the Loa and sitting the spirit were more tied into this voodoo perspective. So here, how are we doing? I'll just give you my commentary here. Given this narrative and the presence of insomnia, agitation, erratic decision-making, and socio-occupational decline, such a person could easily have been prematurely or erroneously diagnosed with psychosis. However, a psychosis diagnosis we withheld this diagnosis when the culture broker tells us on leaving the interview, it was quite late in the interview. That's what we talk about all the time in Haiti. So it kind of radically shifted everything we thought about this patient as we were kind of winding the interview down. These are 2-hour long interviews. We give double the time, because it's with culture or linguistic interpreters. So I was quite shocked because I was worried about her from a psychosis point of view. And you still can have some worry, but I mean, the culture broker just mentioned this. So the case illustrated the complexities of cross-cultural diagnosis and symptom interpretation, especially among patients negotiating hybrid identities, like Voodoo African in this case, Protestant European. So in that case, again, what we did to follow up is we actually had one of the siblings come to a follow-up meeting, and we asked the sibling about what they thought of the person's claims, and they were completely behind it. They didn't find it strange at all. They thought that what she was going through was an understandable dilemma. So we backed way off from psychosis diagnosis, even though there were some other problems, like she was having a little bit of trouble getting settled in Canada, studying and working and so on. But it was maybe for other reasons, maybe other diagnoses, maybe mood disorder would have been more appropriate, you know? Okay, we're winding down to the end here. Liberation time for everyone. Hold on a second. I'm just going to quickly share. Do I have anything else? Oh, just a few conclusions. Okay. Just some take-home messages for everybody. As we've talked about, culture and society do shape psychotic symptoms and disorders at really every step of the way. So from the development of the disorder and the onset all the way through to recovery and treatment and everything in between, there's a dialogue between the society and culture in which we live and what we represent to the people we're working with, and a dialogue with their family, with their lived experience and the stereotypes and the histories that they're working through, some of which are very oppressive, some of which are traumatic. We do have historical legacies of colonialism and racism in Canada, United States, and other places, even though it's falling out of fashion for many people. People are starting to critique and criticize and even dismantle these programs that assess and understand these problems in the lives of our patients. So we need to be advocates. We need to be brave and courageous. We need to continue what we know to be true, what we know to be helpful and necessary for giving quality care to people that we see from all backgrounds in our psychosis clinics. We need to exercise some caution regarding cross-cultural diagnosis of psychosis, and specifically in Black communities, members of Black communities. We may defer formal diagnoses of psychosis for some time to see if mood disorders emerge, or PTSD or autism spectrum disorders, which may be obscured by the way we've come to understand and react to members of Black communities just by virtue of where we've grown up and the society in which we live. Research needs to refine definitions of symptoms and disorder, investigate cultural explanations of distress and insight concepts, evaluate traditional therapies, and adapt medical psychological interventions, which is what we're trying to do in this current project, is to adapt for specifically for Black community members of Black communities the early psychosis interventions that we've learned about and received over the course of our training. Finally, listening to patients is all, as I'm sure you do this all naturally, listening to patients and their families while recognizing the limits of mental health perspectives will encourage culturally appropriate approaches to emerge to the psychotic symptoms and the dilemmas that our patients with psychotic symptoms are living. So I just leave it to, that's what I had prepared for you. If there's any questions, please let me know. I think I didn't share my email address. Whoops. I always forget to do this too. People, eric.jarvis@mcgill.ca. If anybody has questions, please, if it's easier to talk one-on-one, that'd be great. You can certainly talk to Alessandra McLobchich as well if you have questions. If you need to have a cultural consultation, you can call Antonella Clarici at the Jewish General at 25655. She can give you some practical advice or guidance on some of the cases you may be seeing that are quite difficult or thorny. You may not know what to do or how to proceed. If someone is claiming racism or claiming discrimination, or has had severe police involvement, like my poor patient who was knocked to the ground by the police car, or other ones who've been in the ICU from police beatings, you can let us know. We'll try to give you some resources and guidance. These are all the kind of things we can try to help with.